Morning, everyone. Is my voice clear and my video clear? Okay, amazing. Hi, Kara, Sheila, Daza, Najati. Okay, that's great. Okay, how are you doing, guys? So, good morning or good evening, depending on where you're watching us from. Let me introduce myself. So, this is Mafdy. I have passed my USMLE Step 1 and Step 2 CK with a score of 276. And today we'll be going through a very rapid high-yield review for cardiology for step 2 specifically, and it may be also helpful for step 1, and it will be helpful for step 3 as well. So before we go ahead and start, if you haven't, guys, checked our high-yield PDFs, they are free and they cover most of the high-yield concepts you need to know for your exam. Check out them for free. And if you're also interested in one-on-one tutoring and you need more help with uh, someone to help you and guide you and with an individual study plan. Check out also our one-on-one tutoring. We can offer you a 30-minute free session before you commit to one of our packages. And for if you're studying now actively for either your step 1, step 2, or step 3, check out our Synapse QBank, which covers also the most important high-yield concepts. It's just 1,500 questions, so it's much more efficient and it is more nbme relevant and exam relevant. And also, if you like courses and you're a courses guide, so check out our 7-day high yield live bootcamp, which also covers the most important concepts in just 7 days, where you have like 10 hours of daily sessions covering the most important things that show up on the exams. Without further ado, guys, let me share my screen and we'll go ahead and start our session. So, guys, I need you to agree with me in the chat that you feel free to ask questions. I need you to be interactive. So in this session, we're gonna cover half of it is going to be for one-liner concepts, okay, where we understand concepts together through a one-liner question, and I need you to answer those questions. And the other half of the session, it would be practicing what we've learned through those concepts through real questions from our QBank. Okay, so can you guys agree with me before we start that you will stay interactive and answer questions with me? Okay, amazing, amazing Zuzu, amazing Carol, amazing guys, amazing all. Okay, so what are we covering today? We are covering the most important parts, which is vascular disorders, okay, arrhythmias, structural heart disease, and ischemic heart disease. We'll cover each of the high-yield concepts in each of those topics. Okay, so let's start by vascular disorders. So we're having a 70-year-old man. He presents with an abdominal pain, okay, and a pulsatile abdominal mass. What is the single most important risk factor for this condition? So, guys, first of all, what do you think this patient might be having, and what is the most important risk factor for him? Amazing, 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 all of you. So, this patient, as all of you guys are saying, he's probably having abdominal aortic aneurysm. Okay, what is abdominal aortic aneurysm? It is dilatation, okay, of the aorta, where it's becoming ectatic. Okay, and how does it present? It usually presents with a pulsatile abdominal mass. Sometimes it's totally asymptomatic even. Okay, so what is the most important modifiable risk factor for abdominal aortic aneurysm? It is smoking. Okay, guys, do you know when do we start screening for abdominal aortic aneurysms? When do we start screening for abdominal aortic aneurysm? We start at the age of 65. Amazing, amazing, all of you guys. So we start screening at the age of 65. And do we screen any patient? Like at the 65 for abdominal aortic aneurysm? No. Specifically males, okay? And they have to be at least smoked one cigarette in their life. They have to have ever smoked. So any male, guys, patient, and he has ever smoked in his life, he's eligible to do the abdominal aortic aneurysm screening at the age of 65. Okay. So the most important modifiable risk factor for abdominal aortic aneurysm is smoking. Okay, but what is the most important modifiable risk factor for aortic dissection? So we have aortic dissection, which is an intimal tear. Okay, and we have abdominal aortic aneurysm. Amazing. Aortic dissection, the most important modifiable risk factor is going to be hypertension. Okay, great. What if I ask you, what is the most important modifiable risk factors for strokes? What is the most important modifiable risk factor for strokes? All those are important questions. Amazing. Also, The most important modifiable risk factor for strokes would be hypertension. Okay. And what is the most important modifiable risk factor for ischemic heart disease? Most important modifiable risk factor for ischemic heart disease. Modifiable. Age is not modifiable. So look, guys, look, the most important modifiable risk factor is also smoking. So smoking is the most important modifiable risk factor for two things. Actually, even three things that are very important. Abdominal aortic aneurysm, okay, ischemic heart disease, and even, guys, pancreatic cancer. Pancreatic cancer, the most important modifiable risk factor is smoking as well. Okay, so let us see this one here. We're having a 60-year-old man. He presents to us with tearing chest pain. And this tearing chest pain is radiating to the back. And the blood pressure is 180 over 105. Chest X-ray shows a widened mediastinum. Okay, what should be your next step in management? Amazing, 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 amazing. So, guys, what is this patient having first of all? I'm seeing this patient, he's having tearing chest pain, and this chest pain is radiating to the back, okay, with a widened mediastinum. This means that the patient is having aortic dissection. What is aortic dissection, guys? This is the aorta, okay, and this is the, you know, the any vessel is contained of like an adventitia, media, and intima. In dissection, it's an intimal tear, okay, where you have an intimal tear of the aorta. This is leading to acute chest pain, okay, with widened mediastinum. Okay, the first and most important thing, guys, to do in patients with aortic dissection is to give them an antihypertensive. Antihypertensive. Why, guys? Why an antihypertensive? Because as we said, in aortic dissection, the most important modifiable risk factor is hypertension. This hypertension leads to increase of the tear of the intima. So you need to give an antihypertensive as soon as you can to decrease the shear stress on the wall and then deal accordingly. So the first thing when you suspect aortic dissection, I want you guys to give specifically IV labetalol. Okay, you can give IV nitroprusside, but it's not the best option because it will cause something called reflex tachycardia, and this is going to increase even the shear stress on the wall and maybe even deteriorate the intimal tear. So the best modality for aortic dissection is going to be IV labetalol. Okay, so now we've given the antihypertensive. So now you have seen a patient with tearing chest pain. Okay, he also have widened mediastinum. And sometimes they have different, like differential blood pressure. What is differential blood pressure? They have blood pressure differences in both arms because sometimes the dissection includes the subclavian vessels. So it creates this difference in blood pressure between the arms. Okay. Then the first thing you need to do is give the labetalol. That's the first thing you need to do, or give an antihypertensive. Okay. Second thing, you ask yourself, is the patient stable or unstable? Okay? You ask yourself, is the patient stable or unstable? If the patient is stable, guys, you go ahead and do a CT angio. If the patient is stable, you have the time to confirm. Okay, you go ahead and do a CT angiography. Okay. If the patient is unstable, on the other side, you go ahead and do something we call transesophageal echo. We do a transesophageal echo. Amazing. Why transesophageal? Because, guys, the aorta is a posterior structure. You cannot visualize it by transthoracic aorta. Echo, sorry. Okay? So if the patient is unstable, you're going to do an echo. Okay, great. Then, based on its type, if it's type A, okay, aortic dissection type A, it means it includes the ascending aorta. You know, guys, we have the ascending aorta and we have the descending aorta. If it includes the ascending aorta, the dissection is the ascending aorta, you need to do surgery because this is very lethal because it can cause problems with, can cause aortic regurg. Okay, so you need to do surgery for type A aortic dissection. If it's type B, then you can just, type B means it's including the descending aorta. The descending aorta is not as dangerous. So you need to give just medical treatment would be enough. Okay, so again, when to suspect aortic dissection, tearing chest pain, radiating to the back, widened mediastinum, differential blood pressures in both arms. Okay, You give the most important thing you need to do is give the antihypertensive, the labetalol, then ask yourself, is the patient stable or not? You'll choose the imaging based on stability, and then based on the type of the aortic dissection, you are going to choose the surgery. Okay, so this is for aortic dissection. And again, the most important modified risk factor for it was hypertension. Let us see this one. We have a 40-year-old man. This guy is coming to the clinic and he's found to have blood pressure of 150 over 90. What is your next step in management? So we're having a guy, he just comes to maybe a routine visit and we're finding his blood pressure elevated. What should we do? Okay, amazing, 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 amazing. Look, so it's very important to know how nbmes think about the right approach for blood pressure. Okay, so first of all, the patient comes to you, he's having a high blood pressure. Okay, great. Then, should I start antihypertensive just directly because he just came to the office and he's having high blood pressure? No. You need to know, you either repeat the measurement after 2 weeks, or you do something we call the home ambulatory measurement or home ambulatory measurement. Okay. What is home ambulatory measurement? You put a cuff and you just monitor the blood pressure over the day. Okay. Either this or that. Great. Then, if the patient is shown to be also hypertensive on those measures, okay, then what should you do? The first line treatment, guys, the first line treatment that the NBMEs love, okay, for high blood pressure is thiazide. Unless, I always say like this, always give thiazide unless there is either an indication for another drug or a contraindication to give thiazide. For example, if the patient, guys, is having diabetes mellitus, would I still give thiazides? Would I still give thiazides? No. What would you give? You would give ACE inhibitors or ARBs because they are the first line in patients with diabetes because they are renoprotective, guys. Okay. If the patient, guys, is having migraines, would you still give thiazides? Would you still give thiazides? No. What would you give? You would give beta blocker because it helps with the blood pressure, it helps with the migraines. Okay. If the patient is pregnant, would you still give thiazides? No, you need to give something that is not teratogenic. You can give something like nifedipine, okay, or labetalol. Those are the most commonly used now. Okay. Hydralazine also can be used, methyl dopa can be used, but hydralazine is more used in emergency cases. Okay. So for example, those are indications to give other drugs. Okay. However, guys, if a patient has gout, or he has high uric acid, would you still give him thiazides? Of course not, because guys, remember thiazides, they cause hypergluc. What is hypergluc? Hypergluc is hyperglycemia, hyperlipidemia, hyperuricemia, and hypercalcemia. So thiazides are contraindicated actually in patients who have gout. Okay, so you would not use thiazide. You can use any other thing like ACE inhibitors or calcium channel blockers or beta blockers. Okay, so this is how you approach high blood pressure on NBME. It's very simple. A patient comes to you with high blood pressure, okay, you repeat it. Okay, it's still elevated, you start thiazide, unless there is an indication like diabetes, migraine, pregnancy, okay, or there is a contraindication to thiazide like gout. Okay, African Americans specifically, they love to give them thiazides, but in general, I've noticed that they love thiazides at the first line treatment. Okay, great. So this is for blood pressure. Let us see this one here. We have a 28-year-old woman. Okay. She presents to us with severe hypertension. On exam, a systolic diastolic brew is heard in the upper abdomen. What is the next step in management? Guys, what is this patient having? Amazing, 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 all of you. Good job, guys. So, what would you do? What would be your answer? You should do a renal artery Doppler ultrasound. Okay, great. So, this is renal artery stenosis. Look, how did I know this? First of all, renal artery stenosis, okay, can be due to causes. Renal artery stenosis can be due to causes. If the patient is young, okay, it would probably be fibromuscular dysplasia. If the patient is old, it would be probably due to atherosclerosis. Okay, great. What's the problem in renal artery stenosis? You have the kidneys, you have the artery. The problem is that you have it stenotic, so there is no perfusion to the kidney. And when there is no perfusion to the kidney, what is the substance that gets released? It is the renin. And of course, you know, guys, the renin activates the RAS system, and now you are going to have a high blood pressure. Okay. And what happens, guys, to the potassium, okay, and HCO3 in patients with renal artery stenosis? What happens to them? What do you think? Amazing. Guys, whenever I see a patient with high blood pressure and hypokalemia and alkalosis, I suspect this is hyperaldosteronism, either primary hyperaldosteronism or secondary due to renal artery stenosis. Why does this happen? You know, guys, when you activate the RAS, what is released at the end is aldosterone. And what does aldosterone do in the collecting ducts? Aldosterone absorbs sodium, right, and wastes what it wastes, potassium and hydrogen. So the patients end up having hypokalemia, okay, and they end up having metabolic alkalosis, okay. So that, and it all, lots of the times it presents with a brew. Why a brew? Because the renal artery stenotic. So whenever I have a patient with high blood pressure and a brew, I know this is renal artery stenosis, and we've understood why in the first place it causes hypertension. Okay, how to diagnose it? You do a renal Doppler ultrasound. Okay, or if you don't see renal Doppler ultrasound in the choices, go for any modality that would visualize the vessels. Great. Then we will come to the treatment. Treatment for renal artery stenosis. Treatment for renal artery stenosis. Look, I break it down like that. If the patient is a child, okay, what would you do? And if the patient is an adult, what would you do? So if the patient is a child, guys, can you give ACE inhibitors? If the patient is a child, can you give ACE inhibitors? No, you cannot give ACE inhibitors to children. It's contraindicated. What do? You do angioplasty. You fix the vessels. You do angioplasty. Okay. If the patient is an adult, how do you treat them? You treat them with ACE inhibitors, okay, or ARBs, but usually we use ACE inhibitors. Okay, great. But what if you guys give the adult ACE inhibitor? Okay, what if you give the patient ACE inhibitor and now after giving ACE inhibitor they start having deteriorating kidney function tests? Then what is this? Then this, guys, you suspect then that this patient is having bilateral renal artery stenosis. Okay, then you will have the patient having bilateral renal artery stenosis, and actually in bilateral renal artery stenosis you cannot give ACE inhibitors, you need to do an angioplasty. So to recap, whenever I see a patient with high blood pressure or an aberru or hypokalemia and metabolic alkalosis, I start suspecting renal artery stenosis. What is the measure? What is the modality that I'm going to do? I'm going to do renal Doppler ultrasound. If not there, I would go for CT angio. Okay. Then how do we treat it? Okay, if it's a child, angioplasty. If it's an adult, ACE inhibitors. And the thing that they love to ask about, if you give ACE inhibitors and the patient starts deteriorating, the patient is having bilateral renal artery stenosis. Okay. Now let's go into some of the high yield arrhythmias. So let us see this one. We are having a 60-year-old man, and he's having with hypertension and ischemic heart disease. No, actually, ACE inhibitors are the treatment for unilateral renal artery stenosis in adults. Okay, because it blocks the RAS activation and causes the treatment of the blood pressure. So blood pressure is 70/40, and heart rate is 167. ECG shows atrial fibrillation with rapid ventricular response. What would be your next step in management? Amazing, amazing. Okay, so before we answer this question, I see, guys, some students like struggling with tachycardia or arrhythmias, when in fact they are very, very simple if you know the right approach that the nbme wants you to know. So what is the simple approach for tachycardia? Look, in any tachycardia, in any tachycardia, I ask myself the most important question. Is the patient stable? Exactly. or unstable. Okay. If the patient is unstable, stable, guys, you know, of course, it means low blood pressure and high pulse, okay, or low blood pressure. And if or the patient is stable. Okay. If the patient is unstable, any patient who's unstable and has tachycardia, we need to do what? Synchronized cardioversion. Synchronized cardioversion. Okay. Great. It's type of a shock. If the patient is stable, though, you would treat according to the type of tachycardia, and we will know more about types of tachycardia. Okay. However, there is an exception to this. There is something called pulseless, pulseless tachycardia. Pulseless tachycardia. So, of course, guys, you do not need to ask yourself, pulseless tachycardia, is it stable or unstable? Because pulseless tachycardia means, guys, that there is no pulse. Of course, the patient would be unstable. Okay? So, what is pulseless tachycardia? Again, it's tachycardia on the ECG, but you cannot feel a pulse. This is pulseless tachycardia. What is the first thing you need to do in patients with pulseless tachycardia? Exactly. In patients with pulseless tachycardia, first thing you need to do, and this is the most important thing, you consider them as they are dead because they have no pulse. You go ahead and do the CPR. You go ahead and do the CPR, and they ask about this. Okay. But what if the patient has pulse tachycardia, do the CPR, but you see that the patient is having ventricular fibrillation? If the patient is having ventricular fibrillation, what would you do? Exactly. Here you do defibrillation. Amazing, guys. Defibrillation. Okay. Or the other name for it is unsynchronized cardioversion. Unsynchronized cardioversion. Okay, so tachycardia. How to approach it? I ask myself, patient stable or unstable? Unstable, I go ahead and do synchronized cardioversion. Stable, I treat accordingly, as we will talk about. Pulseless tachycardia, you need to start with the CPR, and if the patient has VF, you do the defibrillation. Okay, this guy, I'm saying he's unstable. Okay, whatever the type of tachycardia, I need to do for him synchronized cardioversion. Okay, then let us see this one here. We're having a 23-year-old woman presents with palpitations. ECG shows regular, narrow QRS complexes at 180 beats per minute with no visible P waves. What is the drug of choice? What is the drug of choice? Amazing. So, guys, narrow QRS complex regular tachycardia. Look, narrow QRS complexes regular tachycardia, needle shaped like this is going to be supraventricular tachycardia. So, for example, here you see, guys, needle regular, okay, needle-like shaped regular tachycardia. This is SVT. Amazing. And guys, how do you treat SVT? SVT, if the patient is unstable, as in any tachycardia, we do synchronous cardioversion. But we're talking about if the patient is stable. First thing you need to do, guys, is actually do vagal maneuvers. Vagal maneuvers. What are vagal maneuvers? Vagal maneuvers, you know, like Valsalva, like carotid body massage, like ice in kids. Okay, that's the first thing you need to do. Second thing, if vagal maneuvers did not work, you go for a drug called, very importantly, guys, called adenosine. Okay, and they'll ask about this out. So this is for supraventricular tachycardia. And guys, where is the most common origin for supraventricular tachycardia? It is the AV node. AV nodal reentrant tachycardia. This is the most common origin, the most common cause for supraventricular tachycardia. And supraventricular tachycardia, guys, lots of the times comes in paroxysms. Okay, it's intermittent. It comes suddenly and goes suddenly. You need to suspect supraventricular tachycardia. So here, guys, the choice for this one would be adenosine. So reentrant tachycardia, you not need to know the details about it. You just need to know that it causes supraventricular tachycardia. It's the reentrant circuit in the AV node. That's all what you need to know about it, that it causes supraventricular tachycardia. Okay, this here, guys. What about this tachycardia here that is looking weird all over the place? What is that? Amazing. Amazing. But what type of ventricular? This is probably, guys, this here is torsade de pointe. Guys, it is chaotic all over the place. Chaotic all over the place, torsade de pointe, or the other name for it, polyventricular tachycardia. Okay, guys, what is the treatment? And this is very high yield for torsade de pointe. Amazing, amazing. The treatment for toussaint de pois, of course, as long as they're stable, you give magnesium sulfate. Very, very important, guys, in high yield. And what other conditions? In step two, in general, we need to give magnesium sulfate. So toussaint de pois is one. You can give it in patients with preeclampsia, or eclampsia, okay, severe features. And most importantly, the one they love to ask about is patients with preterm labor. Preterm labor patients or preterm patients less than 32 weeks, because it improves the it decreases neurological problems. Okay, exactly. It's neuroprotective. Neuroprotective. Decreases the risk of cerebral palsy. Okay, what about if I ask you about this tachycardia? What about if I ask you about this tachycardia? What does it look like to you? Because I'm saying irregular, okay, tachycardia, and there is no P waves. Amazing. This is going to be AFib. AFib, guys, what is the most important thing to do in patients with AFib? With chronic AFib specifically, the most important thing is anticoagulation. Anticoagulation, even more important than rhythm or rate control. Anticoagulation, and we usually tend to do rate control for patients with AFib. Okay, if they need it. If they're having tachycardia, we give them beta blockers or calcium channel blockers. But the most important thing that they love to ask about is to give anticoagulation in patients with AFib. Okay, this wide complex tachycardia that looks like mountains. So mountain looking, this is going to be ventricular tachycardia. Okay, needle shape, this is going to be supraventricular. Okay, great. Okay, guys, what do you think this weird ECG is showing me? Amazing, Carol, amazing, amazing, guys. This is Wolf Parkinson's white. Again, you should be familiar with it. You see, guys, the slurred U wave, okay, the slurred wave and the short PR interval. Slurred wave. Okay, so this is going to be WBW or Wolf Parkinson's white, and actually it also causes supraventricular tachycardia. Guys, can you give beta blockers in patients with Wolf Parkinson's white? Can you give beta blockers in patients with Wolf Parkinson's white? Can you? No, you cannot. Why, guys? Because look, this is the heart. What is the problem with Parkinson's white? It's an accessory pathway. Accessory pathway, okay, that leads to actually also supraventricular tachycardia. So imagine you give beta blockers to control. Now the accessory pathway doesn't like wouldn't go to AV node at all, and would keep having this reentrant tachycardia. So you would even have like it would precipitate attacks of supraventricular tachycardia. So beta blockers are contraindicated in patients with Wolf Parkinson's white. We can give them procainamide. We can give them procainamide. Okay, great. Let us check this one here. We are having a 65-year-old man, and he collapses suddenly at home. Bystanders initiate CPR. Okay, EMS arrives and finds no detectable pulse with organized electrical activity on ECG. What is the next best step in management? Amazing, guys. Guys, this patient is having what? What have we discussed? This patient is having here. Amazing. He's having pulseless electrical activity or pulseless tachycardia, and you need to do what? You need to continue the CPR and even give epinephrine every 3 to 5 minutes and keep repeating that till they have a shockable rhythm. Okay, so we will continue CPR. Not immediate defibrillation because this guy is not having ventricular fibrillation. This patient is not having ventricular fibrillation. Yes, he's having pulses electric activity, but then fibrillation is not organized electrical activity. It's chaotic, okay? It's literally like the ventricle is not pumping at all. It's like fibrillating. So it shows chaotic on the ECG and it's not organized, okay? Great. Let us see this one here then. We're having a 50-year-old man. A 50-year-old man with hypertension, and he has a first degree AV block. What is the next step in management? Okay, Baker, Lavender, Madiha. Okay, guys, but take care. Take care, guys. So you're answering this. This patient is having tachycardia or bradycardia. He's having, guys, heart block. Heart block. Okay, so let's go through heart blocks and then get back to this question. Okay, so if I show you this picture, This is this patient having. This patient, is coming with syncope, maybe some palpitations. That's it. And I do the ECG, I see that. Okay, what is that? He's having prolonged PR interval. Guys, PR intervals are usually just 5 small squares. If they're more than that, they are prolonged. But they are constant. They are constant. So what is this patient having? He's having a first degree heart block. Okay, guys, what is the treatment for first degree heart block? Actually, nothing. You just reassure the patient. Reassure the patient. Okay. What about if I show you this one here? I am seeing prolonged PR intervals, prolonged PR intervals. It keeps prolonging, prolonging, prolonging till one beat is dropped. What is this? This is what we call second degree heart block, specifically Mobitz type 1. Guys, how do we treat this? How do we treat Mobitz type 1? Do we do anything? No, guys, we do not do anything. We just reassure as well. Reassure as well. Okay, great. What about this one? I'm having constant PR intervals, and out of nowhere, you dropped a beat. What is this? This is second degree heart block, Mobitz type 2. Mobitz type 2. Okay, great. Guys, what do we do for this? Do we treat this? Yes, guys, we do for, so starting from Mobitz type 2, you need to put a pacemaker. You need to put a pacemaker, okay? Amazing. And guys, this last one where you have regular P waves, okay? Regular P waves, and regular R waves, which is regular ventricular contraction, but there is no relation at all between this and that, which is going to be third degree heart block. This is third degree heart block, and of course, also you need to put for it a pacemaker. Okay, amazing. So if we get back to the question, I think this patient just have first degree heart block. So does she need anything? Does she need anything? No. She needs just reassurance and observation. Okay, great. So guys, what are important things actually that may cause heart block? The two most important things I need you to know for USMLE that causes heart block, of course, first one is Lyme disease. Okay, Lyme disease, guys, is very high yield. How do we treat Lyme disease generally? Lyme disease, we treat it generally with doxycycline. Okay, generally. Okay, but if the patient is pregnant, so generally, let me write general doxycycline. If the patient is pregnant, what do you give? Amazing, you give amoxicillin. Amoxicillin. Okay. If the patient, however, is having cardiac, okay, or neurological abnormality, so heart, okay, or neurological problem like heart block, or say if you're having meningitis or neuropathy or something like that, what do you give? What do you give? Amazing, you start giving ceftriaxone. Also, the treatment for Lyme disease is very, very important. Okay, great. And the other high yield thing that causes heart block, guys, is actually, you know what type of STEMI can cause heart block or problems with rhythm? What type of STEMI? The inferior wall myocardial infarction. Inferior wall STEMI, exactly affecting the right coronary artery, because the right coronary artery gives the PDA in most people, and this gives the AV node and SN node. So when you have infarction of those, you have problems with rhythm. It can lead to heart block as well. Those are the most important two things that can cause heart block. Usually also sarcoidosis can cause it, but those are the two most important things. Okay. Now we finish, like we've covered the most important parts of vascular disorders. Okay. And amazing, Tanya, that's the one as well. Neonatal heart block in SLE. Good job. And we've covered the most important parts for arrhythmias. Now let us see structural heart disease. Structural heart disease includes heart failure, myocardial diseases, and pericardial disease. So let us see. We're having a 28-year-old man. And this 28-year-old man, he presents with shortness of breath, orthopnea, bilateral basilar crackles, and an S3 after a recent flu-like illness. What is the most likely diagnosis? Amazing, amazing, all of you. Look, guys. So if you have any patient who's young, okay, and he presents to me with acute heart failure symptoms out of nowhere, so like a 20-ish, 30-ish, or even a kid presenting to me with this acute heart failure, orthopnea, dyspnea, distended jugular veins, bibasilar crackles, S3 acutely, I suspect myocarditis. Sometimes even in step 2, they do not tell you there was a viral infection. Sometimes on step 2, they do not tell you there was a previous virus infection. Okay, so whenever you see acute heart failure in a young patient without risk factors, without nothing, suspect myocarditis, especially if they have mild grade fever. Okay, so myocarditis, exactly as you said, is most commonly caused by Coxsackie virus. Okay, if I ask you, what is your next step in diagnosis? So you already know now the diagnosis. If I ask you, what is your next step in diagnosis? Amazing. No, look, guys, I see lots of students making this simple mistake, which is totally avoidable. Look, guys, if you have a problem within the myocardium or the pericardium, please do not go ahead and do an ECG. Okay, if you and I'm gonna say it again, if you have a problem with the myocardium, okay, or the pericardium, please do not go ahead and choose ECG as the right answer. It is echo, because echo is the thing that diagnoses structural abnormalities in the heart. Okay, so we're gonna go ahead and do an echo. Okay, Coxsackie also virus can cause pericarditis. Okay, Coxsackie virus can cause three important things actually in USMLE. So Coxsackie virus can cause three important things. What are the three important things? It can cause, first of all, pericarditis. Pericarditis. Pericarditis, the most common cause of pericarditis, guys, is actually viral. Okay, and it can cause myocarditis. And it can cause a very, very important disease called herpangina. What is herpangina, guys? Herpangina, it looks like herpes, but it doesn't affect the lips or the superficial oral mucosa. It affects usually deeper buccal mucosa, and it can be associated with the hand, foot, and mouth disease. So actually, hand, foot, and mouth disease, um, like part of it is the herpangina. So the mouth affection is called herpangina, and you can also have hand and foot affection, but you can also only have the herpangina, which is the isolated mouth affection. Okay, so Coxsackie can cause herpangina and hand, foot, mouth disease. Okay, and by the way, the treatment for all this is supportive treatment specifically for hand, foot, and mouth disease. Okay, great. Let us see this one. We're having a 50-year-old woman. Okay, she's presenting to me with exertional dyspnea and leg swelling. Exam reveals jugular venous distension, loud P2, clear lungs, and hepatomegaly. What is the most likely diagnosis here? Amazing. Nadares, Abtin, Taban, Muhammad, Gorjot, Bakr, Julio, Ashwarya. Amazing, amazing, amazing. Okay. So, but we're having, okay, great, great. So what is the patient having? What is the patient having? So this patient, 50-year-old, she's having dyspnea, like swelling, jugular venous distension. Those are signs of heart failure. But she's having loud P2. Loud P2, guys, mainly USMLE means the patient is having pulmonary hypertension. Because, guys, if you have, hypertension, this will lead to abrupt closure of the valve, so you have a loud P2 or loud S2. Okay. So pulmonary hypertension, guys, prolonged pulmonary hypertension. The right side of the heart is pushing against a very high blood pressure, so with time it will start to fail. And what are signs of right-sided heart failure? You will have distended jugular veins, hepatomegaly, edema, okay, and of course the orthopnea and the dyspnea, that things that you can see with heart failure in general. However, you would see clear lungs because there is no problem with the left side of the heart. No bibasilar crackles or anything like that. Okay, so this is here right-sided heart failure secondary to pulmonary hypertension. Guys, my question for you, what is the very high-yield disease that causes pulmonary hypertension on USMLE? Okay, cor pulmonale is a right-sided heart failure secondary to a lung problem. Exactly, exactly, guys. So COPD can cause it, but they love to ask about what? Scleroderma, specifically CREST syndrome, guys. CREST syndrome, the calcinosis, the Raynaud's esophageal dysmotility, uh, and the telangiectasias. Okay. So, and scleroducty. So, CREST syndrome is a type of scleroderma. It is associated with pulmonary artery hypertension more, or interstitial lung disease more. No, pulmonary artery hypertension more than interstitial lung disease, guys. Okay, so CREST syndrome, pulmonary artery hypertension more than interstitial lung disease, and they ask about this. Okay, it can cause something called the hypertensive renal crisis. That's another thing. Okay, Great. Or scleroderma renal crisis. Great. What about rheumatoid arthritis, guys? Rheumatoid arthritis. It is more common to cause. It is more common to cause interstitial lung disease or pulmonary artery hypertension? No, it's more commonly to cause interstitial lung disease more. Why? Because the disease itself causes that. And actually, what is the first line treatment for rheumatoid arthritis? Methotrexate. Methotrexate itself also causes interstitial lung disease. Okay, amazing. So let us see this one. We're having a 25-year-old woman, okay, has a grade 2 out of 6 systolic murmur at the left sternal border that decreases with standing, and she is totally asymptomatic. What is the next step in management? What do you think, guys? I need all your answers. Look, so this is something, what is this patient having? Like she's having a systolic murmur, first of all, systolic murmur, and most importantly, she's asymptomatic. Amazing, baby. Asymptomatic. This is what we call something we call innocent murmur. What do we mean by that? This is a murmur. It's a functional murmur or innocent. It's not actually due to a valvular problem. It is not actually due to a valvular problem. Okay, so as long as it's not symptomatic and it is just systolic, we reassure. We reassure. Okay. However, guys, innocent murmurs are never diastolic. Innocent murmurs are never diastolic murmurs. Innocent murmurs are not diastolic murmurs. And of course, if the patient is symptomatic or having symptoms, okay, you need to go ahead and do something like echo. Okay, if the patient's having diastolic murmur or symptomatic, the answer would be echo. Because this is just an innocent murmur, we would just reassure. Okay, let us check this one. So we're having 60-year-old man. And this guy, he presents with acute chest pain relieved by leaning forward. Labs show urea of 132 and creatinine of 3.4. What would be your next step in management? What do you think, guys? Okay, amazing, amazing, amazing. So first of all, whenever, guys, you see a patient with acute chest pain and it's relieved by leaning forward, this can only be one thing. It can be what? It is pericarditis. Okay, so pericarditis generally. Forget about the question for a second. How do we treat pericarditis generally? Or before I ask about the treat, if you have a patient with pericarditis and I tell you what is your next step in diagnosis, should you choose X-ray, echo, or ECG? If I ask you what is your next step in diagnosis, again, guys, please choose echo, not ECG, not X-ray. Okay, you're gonna go for echo. Amazing. And how do you treat pericarditis, guys? How do you treat pericarditis? Amazing. NSAIDs and colchicine. NSAID and colchicine. Okay, great. However, here, so this is in the normal pericarditis, the viral pericarditis. However, here there is a secondary cause of the pericarditis. What is it? This guy is having high urea and high creatinine, and this is called uremic pericarditis. Okay, and uremic pericarditis, you need to do hemodialysis because it's due to the uremia. So you need to do hemodialysis very, very, very. Okay. Sometimes, guys. So what can cause pericarditis, by the way? So what are causes of pericarditis in general? You have the viral or idiopathic. Okay. You have autoimmune, okay, associated with SLE, associated with rheumatoid arthritis. You have the one that is called the Dressler syndrome that happens, guys, after MI with 2 weeks. Okay. And it can be, guys, due to uremia, as we said, sometimes even due to malignancies. Malignancies can cause pericarditis and sometimes even pericardial effusion. Pericardial effusion up to cardiac tamponade, and we'll talk about this later. Okay, great. And take care, guys. And take care, guys. In pericarditis, you can see ST elevations on the ECG, but they will be widespread ST elevations. Do not confuse this and go for an MI. This is not an MI. If the patient is having acute chest pain and is relieved by leaning forward, probably it's not an MI. MI, if you see wide diffuse ST elevations, this is pericarditis as well. Pericarditis, wide ST elevations. Okay, let us see this one. A 48-year-old man with metastatic lung cancer. Okay? Presents with dizziness, and the blood pressure drops from 94 over 60 to 80 over 50. The exam shows jugular venous distension, muffled heart sounds, and clear lungs. Okay, what would be, guys, your diagnosis here? Amazing, 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 amazing. So, what is this patient having? This patient had a malignancy, okay, and probably the malignancy complicated by it infiltrated the pericardium and complicated by pericardial effusion and up to cardiac tamponade. What is cardiac tamponade? If I imagine that this is the heart. Okay, cardiac tamponade is accumulation of fluid or blood around the pericard or in the pericardium around the heart. So the heart cannot fill. The heart cannot fill with fluid. So if the heart cannot fill, you would have distended jugular veins. Okay, you would have distended jugular veins. Second of all, you have fluid around the heart, so you'd have muffled heart sounds, right? Okay, and because the blood cannot, the heart cannot fill, it cannot also pump adequate fluid, so you'd have hypotension. So you'd have hypotension. Okay, and this is what we call the Beck's triad. The Beck's triad. Guys, whenever you see this, this is going to be cardiac tamponade. Okay, so this here is cardiac tamponade. Okay, again, for cardiac tamponade, what is your next step in management? Very, very important. Amazing. Whenever you see cardiac tamponade, especially guys, cardiac tamponade can happen due to malignancy. Is more commonly even to happen after traumas. Okay, either stab wound or blunt trauma to the chest. The first thing you need to do when you have a cardiac tamponade, please do a pericardiocentesis. This can save the life of the patient. Okay, but however, in this patient who is having a malignancy, after I do the pericardiocentesis, what should I do? In this patient who's having a malignancy, I will probably need to do something we call pericardial window. Pericardial, amazing, David. Pericardial window. What is a pericardial window? Look, guys, because this is a metastasis, the infiltration of the malignancy will keep going and it will keep having recurrent pericardial effusion. So you literally open a window, okay, in the pericardium that opens on the like the skin. Okay, we do a pericardial window for patients with metastatic pericardial effusion or cardiac damage. Okay, so we finished the most important things for um, arrhythmias, vascular disorders, structural heart disease. Let's go into ischemic heart disease, and this will be our last topic for today. Okay, so let's see. This patient, she's 45 years old. Okay, she records exertional heart burn that is relieved by rest. ECG is normal. What is the next best step in evaluation? Amazing. So what is this patient having? I have a patient who have heartburn, and this heartburn is relieved by rest. Okay. What is this? This is probably angina. So look, the answer here is exercise stress test. But let us understand more about ischemic heart disease and how they are like classified. So ischemic heart disease are, hence the name suggests, it's any disease due to narrowing of the coronary artery. Okay. So we have a chronic form, which is angina. Okay, we have a chronic form, which is angina. This is the one that is just due to atherosclerosis. Okay, atherosclerosis, narrowed coronary arteries, pain exacerbated by exercise, relieved by rest, and nitrates. This is it, angina. Okay, and we have something called acute coronary syndrome. No, this is not chronic. This is not the pain that is like, gets worse with exercise. No, this is acute chest pain that sometimes, radiates to the shoulder or the jaw. This is what we call acute coronary syndrome. And acute coronary syndrome can be one of two things. Either unstable angina, can be unstable angina. So unstable angina, guys, presents acutely. Okay? Or it can be an MI, and MIs can be either STEMI, okay, or non-STEMI. STEMI is like complete infarction of the wall, so you'd have ST elevation. Non-STEMI is like subendocardial infarction, or a part of the wall that is infarcted, not the whole wall, and you would have ST depressions most of the time. Okay, so great. So for angina, what is our approach for angina? If a patient has sometimes they don't even tell you chest pain. Sometimes they tell you indigestion after meals or heartburn when the patient is playing with her granddaughter. This is considered angina as well. The first thing you need to do, guys, what is the first thing you need to do for angina? You need to do ECG. ECG. No, the first thing you need to do ECG, normal ECG first. Okay, the normal ECG would probably most of the times be free. Okay, then after that you need to do a stress test. A stress test. You need to stress the heart to see if there is a problem. Okay, so we do two types of stress tests depending on the patient. So guys, if the patient, like has osteoarthritis or he's having the chest pain very severe that he's not even able to walk a block, would you go ahead and do exercise stress test? No, you're going to do something we call pharmacological stress test. Pharmacological, and they ask about this, guys. It's important. Pharmacological stress test. Okay, pharmacological stress test like tolbutamine stress test. Okay, or sometimes called other one called adenosine stress test. Okay, you do pharmacological stress test. However, if the patient is able to exercise, okay, you're going to do a an exercise test, exercise ECG test, exercise ECG. Okay, so this is our approach for angina. Okay, so here we've done the ECG. Okay, now we need to do the exercise stress test. Okay, and again, guys, for ischemic heart disease, when they ask you about a diagnostic measure, please do not go for echo or an X-ray or something like that. For ischemic heart disease, we choose ECG. Okay. Okay, by the way, guys, what are the drugs that you need to give in patients with acute coronary syndrome? What are the drugs that you need to give in patients with any patient with acute coronary syndrome? Amazing. Monabash, most importantly, you need to give, guys, aspirin, okay, and clopidogrel. Aspirin and clopidogrel. Dual antiplatelet therapy, they ask about this a lot. You can give also oxygen, morphine. Okay, that's fine. You can, and also you can give statins. Okay, and you also give sometimes heparin, but not very important. The most two important things they ask about in the drugs used in acute coronary syndrome is aspirin, dual antiplatelet therapy, and the statin. But you can also give nitrates, right? Like nitroglycerin. But do you give nitrates for all patients? Do you give nitrates for all patients? No, it is absolutely contraindicated in patients with inferior wall STEMI. Patients with inferior STEMI or right ventricular infarction, you cannot give them nitrates. It is contraindicated. Why? Because, in right ventricular infarction, it is preload dependent. Okay, it's preload dependent. The right ventricle cannot pump. So now you give nitrates, you venodilate, there is like pooling of the blood in the veins and it's not coming back to the heart. So this even will put the patient in cardiogenic shock and deteriorate the case. Okay, so this is very, very important as well, guys. And of course, in MIs, you do acute coronary syndrome. Of course, the most important thing is to do an ECG. Okay, if you see ST elevations, you do go ahead and do revascularization. If there is ST depression, you follow up with the troponin. If the troponin is elevated, it means it's also non-STEMI, and you need to do revascularization. Unstable angina, the ECG may have changes, but troponin would be normal. Troponin, guys, would be normal in angina. Okay. Great. So let's see this. A 55-year-old man with mitral valve prolapse and a history of ventricular septal defect is scheduled for a routine dental cleaning. What is the appropriate infective endocarditis prophylaxis? Okay. We're having some people say A, some people say E. Okay. Okay, so let's understand. So first of all, guys, when do we prophylact for infective endocarditis? This is very, very important. Very, very important. And they ask about it a lot, guys. So focus with me. What are the indications for prevention with antibiotics for infective endocarditis or prophylaxis? You can help you with that. First of all, patient, I like to break it down like that. The patient and the procedure. Let's start by the procedure because it's very easy. The procedure, guys, it has to be a dental procedure, okay? Especially if it includes the gingival manipulation. Dental procedure, okay. What about the patient? What patients are eligible to have infective endocarditis prophylaxis? Look, only those are patients with VSD or mitral regurg or aortic stenosis. Are they eligible for prophylaxis? No. Look, what are the indications? Previous, first of all, most importantly, previous infective endocarditis. Okay, that's the first one. Second one is a patient with prosthetic heart valve, prosthetic or mechanical heart valve. Okay. Third one is congenital heart disease, but take care, not any congenital heart disease. It has to be cyanotic and not just cyanotic, but it has to be also unprepared. Other than that, guys, please do not give prophylaxis for infective endocarditis. Is going to be the wrong answer. Okay, and how do we give prophylaxis? We give just amoxicillin. It's very simple. Amoxicillin, okay, 1 hour before the surgery, orally. Oral amoxicillin 1 hour before the surgery. If the patient is amoxicillin um, sensitive, he has hypersensitivity, you can give erythronols. But here in this case, the patient actually is not eligible for receiving the prophylaxis. So we're going to go ahead and choose the choice E. Antibiotic prophylaxis is not indicated. Okay, let us check. Mitral valve prolapse is not an indication for infective endocarditis prophylaxis. Nothing, literally, guys, nothing else than those indications are you need to give in. Okay, let's see this one. A 60-year-old man presents with 45 minutes of severe substernal chest pain radiating to the left arm. He's diaphoretic. ECG shows ST elevations in leads V1 to V4. Which of the following antiplatelet regimens should be given initially? Guys, what is this patient having? Okay, amazing, 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 all of you. So this guy, he's having ST elevations, okay? He's having acute coronary syndrome. What is the most important two drugs that we need to give in any patient with acute coronary syndrome? We need to give them aspirin and clopidogrel, as we have said. Okay, aspirin, clopidogrel, as we have said. So, and what's the definitive treatment for STEMIs, guys? It has to be PCI. PCI as long as the patient is within the 120-minute period. Okay, as long as the patient is within the 120-minute period. Okay, and guys, like if you have 2-3 AVF, okay, in the ECG, this is going to be inferior STEMI. Okay, if you have the anterior leads like V1 to V4, okay, this is going to be anterior wall STEMI. Okay. And if you have like the AVL and V5 and V6, this is going to be a lateral wall STEMI. Lateral wall STEMI. Okay, great. Let us see. So here, guys, as you can see, what is this? This is 2 and 3, 2, 3 AVF elevation. So this is inferior wall STEMI. Guys, again, do we ever give nitrates in that? Do we ever give nitrates in that? No. Okay, guys, what I actually need to give? Very important to give in patients with inferior wall myocardial infarction or right ventricular infarction. Amazing. IV fluid. You need to give normal saline IV fluid, isotonic fluid to increase the preload and help with the failing right ventricle. Amazing, guys. Okay. Then let us see this one. Okay, yes, that's right as well, Najat. Let us see this one. A 58-year-old man, he presents to a rural emergency department within 1 hour of chest pain, and ECG shows ST elevations in leads 2, 3, and AVF. The nearest PCI capable facility is 3 hours away. Then what is the next best step? Okay, amazing, 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 all of you. So, guys, so we said that the treatment for myocardial infarction is percutaneous intervention, the PCI, but it has to be within the less than 120-minute period, right? Okay, but what if it's more than 120 minutes? What do we do, guys? If it's more than 120 minutes, unfortunately, those patients are not eligible, okay? And we need to give them the fibrinolytic therapy. What is a fibrinolytic therapy, guys? Those are the like altiplase, exactly, tissue plasminogen activators like alteplases. Alteplase. Okay, guys. Alteplase or tissue plasminogen activator you have three high yield indications we need to give. Very important, guys. Three high yield indications for alteplase you need to know. Okay, most important one actually, guys, is what? The most famous one, stroke. But any type of stroke? No, ischemic. Ischemic stroke, okay? And it has to be exactly with less than in the 4.5 hours window period. In the 4.5 hours window period. Okay, great. What else? The one that we've just mentioned here, MI, okay, more than 120 minutes. Specifically, guys, is STEMI. Okay, specifically STEMI, ST elevation more than 120 minutes. Okay, and the last one, which is also very, very important, amazing Frederica, unstable pulmonary embolism. What do I mean by unstable pulmonary embolism? If you have a massive pulmonary embolism, guys, it is too big that is causing hypotension and tachycardia. You need to give them alteplase as well, although even a mechanical thrombectomy. Those are very, very important as well. Okay, let us see this one. A 60-year-old man. He presents with the chest. No, there is no specific time. No specific time for T. Presents with chest pain at rest. ECG shows T wave inversions and ST depressions in the lateral lead, and troponin is negative. What is the diagnosis here, guys? Okay, Carol, Iris, Tania, Sud. Okay, great, amazing. So, patient having ECG is coming with acute chest pain. That's the first thing, okay? And they're having changes on the ECG, but the troponin, I measure it, it's negative. So this means there is no infarction. So this has to be unstable angina. This has to be here, guys, unstable angina. But what if I tell you, okay, the patient is having weird ST changes or ECG changes, but the troponin is positive? What if I tell you that the patient is having ST depressions and things like that, but the troponin is positive? Then it would be non-stable. Okay, but because here the troponin is negative, it's going to be the unstable angina. Okay, guys, so we have finished our questions or our one-liner concepts, okay, for the most important high-yield things for cardiology. Let us now practice some real questions. Some real questions from our Synapse QBank before we end our session. Okay, so let's apply some of what we have learned. So before, Tanya, this is a good question. Prinzimatal angina or vasospastic angina. This is very important. It is intermittent chest pain, okay, that comes and go. Intermittent chest pain in a middle-aged female that comes and go. This is going to be prinzimatal angina, okay? And actually for prinzimatal angina, the treatment is calcium channel blockers. Okay, exactly. Okay, so let us read together this question and see how it goes. So we're having this patient, you know, guys, nowadays on the nbmes and even the exam, we have lots of those patient chart questions. So in Synapse QBank, we've integrated lots of those patient chart questions. So let's read. Age 66 years old, male, unspecified. For those things, if you read them like very carefully, you take too much time. So you skim through them rapidly and extract the important info that matters. Okay, so 66, male, unspecified, follow-up, okay, great. Returns follow-up for his blood pressure has remained elevated despite the treatment with antihypertensive medications. Okay, lisinopril was added 3 weeks ago. Now, starting lisinopril, he's having fatigue, mild nausea, intermittent anxiety. Okay. He has long-standing bilateral calf pain, hypertension, diabetes, hyperlipidemia, peripheral artery disease. He started lisinopril again 3 weeks ago. Amlodipine, chlorthalidone. Okay, great. Tobacco, he smokes 1 pack, okay, for 42 years. Alcohol not provided. Vital signs, he's having a very high blood pressure. Pulse is fine. The remaining things are fine, and he's having a very high BMI. He's comfortable. Cardiovascular is clear. Lungs are clear. Soft, non-tender. Abdomen is clear. Extremities showing peripheral artery disease symptoms. Okay, skin is normal. Neurological is normal. Lab results are shown. He's having normal sodium. A little bit potassium is a little bit low now. It was normal 3 weeks ago. Bicarb is a little bit higher. BUN and creat are getting higher, and the GFR is getting lower. Which of the following is the most appropriate next step in evaluation? Guys, what do you think this patient is having? Like, what do you think? This guy He had hypertension, okay? And now we've given him ACE inhibitor. But after we give him ACE inhibitors, he's not responsive to them, and even his kidney functions deteriorate massively. Then what is this? This is amazing. Bilateral renal artery stenosis. Okay, and if you have renal artery stenosis, what is the choice that you should go for? I should go for a renal artery duplex ultrasonography. Okay, here is a nice guy's explanation with a figure why each answer is correct and the educational objective, and nice also table comparing the causes of secondary hypertension. Okay, so let's see this one. We have a 55-year-old man. He comes to the office for routine follow-up exam. Okay, and he has a 5-year history of type 2 diabetes, hyperlipidemia. His current medications include metformin, atorvastatin. He feels well and reports no chest pain or changes in vision. He exercises twice a week and follows moderate carbohydrate diet. Okay. He does not use tobacco, alcohol, or illicit drugs. And the temperature is normal, blood pressure is a little bit high, respirations are normal. Repeat blood pressure measurement 15 minutes later is 142/92. Review of his chart, blood pressure readings 146, okay, and 150/92 in his last 2 clinic visits. Over the past 6 months, BMI is 31. There is no peripheral edema. Serum sodium is fine. Serum potassium is fine. Hemoglobin A1C is a little bit high. Urine to albumin creat ratio is high. Serum creatinine is normal. Guys, which of the following is the most appropriate pharmacotherapy for this patient's elevated blood pressure? Guys, this guy is having high blood pressure. And what is he having also? What is he having also? He's having as well concomitant diabetes mellitus, and even he's having, guys, if you look here, he's having a high urine to albumin creat ratio, and urine to albumin creat ratio is the earliest marker for diabetic nephropathy. So we need to give those patients, any patient with hypertension and diabetes, we've agreed you need to give him lisinopril. Other than that, I would have probably gone for thiazides. Okay, great. Let us see this one. We have a 24-year-old woman. She comes to the emergency department because of a 45-minute history of sudden onset palpitations and mild lightheadedness. The symptoms began abruptly while she was reading a book at home. She reports a rapid, regular fluttering sensation in her chest. She denies chest pain, shortness of breath, okay, or prior episodes of syncopes. No significant past medical history. She does not use tobacco or illicit drugs, and she drinks 1 cup of coffee daily. Temperature is fine, blood pressure is fine, pulse is very high, it's 175, oxygen sat is normal, rapid regular pulse, cardiac auscultation reveals normal S1, normal S2, and 12 lead ECG is shown. What do you see, guys, here? What are you seeing here? Amazing, needle-like, again, and paroxysms of tachycardia that comes and go. What is this going to be? This is going to be supraventricular tachycardia. Guys, what is the following? Which of the following mechanisms is most likely responsible for this patient's arrhythmia? Amazing, amazing, amazing. We said, guys, the most common cause of supraventricular tachycardia is reentrant or the AV nodal reentrant tachycardia, which is basically reentrant circuit within the AV node. Okay, great. Guys, how would you treat this specific patient here? If I ask you what is your next step for this specific patient here, what would you say? Amazing, vagal maneuvers. And then if vagal maneuvers didn't work or there is no vagal maneuvers in the choices, you would go for adenosine. What if the patient, this exact patient here, her blood pressure was 80/60? What would you do? Amazing, amazing, amazing. Guys, you do synchronized cardioversion. If she was unstable. However, she's stable. Okay, so we'll probably do vagal maneuvers and adenosine, and this is paroxysmal supraventricular tachycardia as well. Okay, then let us see this one. When ANS. Okay, ectopic atrial focus with increased automaticity. Okay, this can be in cases of atrial flutter. Okay. Oh, D is for AFib. Actually, guys, this is a good question. AFib comes from pulmonary vein ostium. However, atrial flutter comes from the cavo-tricuspid isthmus. Okay, great. Let us see this one. A 78-year-old man. He came to the emergency department by his daughter. Okay. After he fainted while walking to his mailbox, he reports he felt suddenly lightheaded before losing consciousness approximately 30 seconds ago. He was completely oriented but felt profoundly tired. He has experienced progressive fatigue, mild exertional dyspnea, and occasional episodes of dizziness. His medical history is significant for hypertension, diabetes, osteoarthritis. His daily medications include lisinopril and metformin acetaminophen. Okay, great. Blood pressure is fine. Pulse is very low, and this is the important thing. And he's presenting with syncope. Okay, respirations are normal. Patient's currently alert, comfortable. Nothing here for me. Lungs are clear. So slow rhythm. So nothing is remarkable, observable for me. Let's look at the ECG. Let's look at the ECG. So what are you seeing, guys, on the ECG? What do you think this patient is having? So he's having syncope and he's he's having bradycardia. So I'm suspecting already some type of heart block. But what type of heart block is he having? As you can see, guys, he's having regular P waves, and regular R waves or regular ventricular contractions, but they're totally unrelated to each other. So this patient is having third degree heart block. Which of the following is the most appropriate next step in management? It would be amazing. It would be putting a permanent pacemaker. Okay, so let us see this one. A 63-year-old woman. She comes. See. Okay, so this is in patients who have ventricular fibrillation. Okay, patients who had ventricular fibrillation at all. We can use it in patients with hypertrophic obstructive cardiomyopathy if they had sudden cardiac arrest before. Okay, for patients with high HOCM if they had sudden cardiac arrest before. B, guys, this is unsynchronized cardioversion. Okay, unsynchronized cardioversion is the defibrillation. We will use it in ventricular fibrillation, right? Okay. So a 63-year-old woman comes to the emergency department due to a 5-day history of progressive shortness of breath, fatigue, chest heaviness. She has a history of stage 4 breast cancer with known pulmonary and bone metastases. 1 month she was admitted to the hospital for acute dyspnea and hypotension. Echocardiography at the time revealed a large pericardial effusion with cardiac tamponade. She underwent an emergency pericardiocentesis which yielded 600 milliliters of serous sanguineous fluid, and cytologic analysis confirmed the presence of malignant cells. Her current medications today are okay, some chemotherapy. Today her temperature is fine, blood pressure is high, pulse is high, respirations are high, pulse is a little bit low, distant heart sound, jugular venous distension. Okay, the lungs are clear, auscultation bilaterally, and there is bilateral trace edema found. Guys, what is this patient having? Echocardiography demonstrates a large pericardial effusion with early diastolic collapse. Which of the following is the most appropriate next step in management? Guys, this patient is having, amazing, as all of you are saying, she's having already cardiac tamponade, but why is she having it? Why is she having it? It's associated with malignancy, and we said, guys, in malignancy, what do you need to do? You need to do a pericardial window. Amazing, guys. Okay. However, if this was just a normal pericarditis, okay, I would go give NSAIDs and colchicine, but this is due to a malignancy, pericardial effusion, even leading to cardiac tamponade due to a malignancy. This is, guys, how a cardiac window looks like. We open literally a window in the pericardium to drain the fluid. Okay. Let us see this one. A 38-year-old man is brought to the emergency department by his wife because he has been acting strange and complaining about his chest for the past 2 days. Okay. 3 weeks ago, he returned from a 2-month humanitarian mission in sub-Saharan Africa where he worked in a community health clinic. Since returning, he has had intermittent low-grade fevers, poor appetite, unintentional weight loss, initially attributed to travel and irregular meals. During the past days, he had developed sharp chest pain discomfort, becomes worse when he lies flat, and improves slightly when he leans forward. So I'm already thinking what the patient might be having. He denies productive cough or hemoptysis while overseas. He has no history of coronary artery disease. He's a little bit feverish. Everything is looking fine to me. He appears fatigued, cardiac auscultation, faint intermittent scratching sound. Okay, leukocyte is normal, hemoglobin a little bit low, ESR is a little bit high. Which of the following is the most appropriate next step in management? So guys, what do you think this patient is having? And if we look at the ECG, we're having some ST elevations in the leads. Okay, what is this? Diffuse ST elevation. Patients with acute chest pain relieved by leaning forward and gets worse by leaning back. What is this guy having and what should you do next? I need answers. Okay, so what would be your answer, guys? Okay, so let's see. We're having next step in management. Aspirin, clopidogrel. No, this is not MI. Nitroglycerin, also not MI. Tubercle skin test, no need. Not ripe. Okay, what do we need to do? We need to actually, guys. So would you go for E or F? E or F? So actually, guys, we need to do a transthoracic echo first. We need to do a transthoracic echo first to diagnose the patient. Diagnosis, then treatment, because sometimes this pericarditis can be complicated by pericardial effusion. So we need to make sure there is low pericardial effusion. So we do, guys, the echo, then we do the colchicine second. Okay, let us see this one. No, it's not TB. This is not TB. It may be TB. It may be TB. Yes, sorry, it may be TB. Okay, but we do the echo to diagnose. Okay, first, and then we will give ibuprofen plus colchicine, and we need to treat the TB, of course. Okay, but we need first thing here to do because he's having pericardial effusion. We need to do the echo diagnosis first. Then we will treat the TB. Okay. Okay. So let's see this one. 64-year-old man. He comes to the emergency department by ambulance. Okay, due to severe crushing chest pain. Okay, began 1 hour ago. He says the pain radiates to his left joint is accompanied by profound nausea and sweating. His medical history includes hypertension, lipidemia, diabetes. Okay, lots of drugs, metformin, lisinopril. He was given 324 milligrams of aspirin. He appears pale, anxious, and diaphoretic. Blood pressure is very low. Pulse is high. The physical exam shows jugular veins distension. Okay. The lungs are clear bilaterally. Cardiac examination shows a irregular rapid rhythm with no murmurs. The abdomen is soft, tender, and the extremities are cool with delayed capillary fill. The 12-lead ECG is shown. So first of all, what do you think this guy is having? I'm having a pain in the acute chest pain to the jaw. So I know this is acute coronary syndrome, but let's look at the ECG. What are you seeing, guys, in this ECG? I am seeing 2, 3, and AVF elevations. 2, 3, and AVF elevations. So this is probably inferior STEMI. Okay. Then in inferior STEMI, guys, what did we say we need to do? Can we give nitroglycerin? Can we give nitroglycerin? No, the most important thing for me is to give fluids, okay, to increase the preload and supply the infarcted ventricle. Okay, let us see this one. 62-year-old man. He comes to the emergency department because of sudden onset substernal chest pain that began 45 minutes ago. He was resting at home when he developed a severe crushing sensation in the center of his chest. The pain is accompanied by nausea, shortness of breath, and profuse sweating. Significant for hypertension, type 2 diabetes, hyperlipidemia. Medications include lisinopril, metformin, and atorvastatin. He smoked 1 pack of cigarettes daily for 40 years. Okay, temperature is normal, blood pressure is high, pulse is high, oxygen is good, physical exam anxious, diaphoretic man, clouching his chest. Okay. Lungs are clear to auscultation bilaterally, reveals the rapid regular rhythm with late diastolic sound at the apex. No murmurs or drops are heard. Bilateral, radial, and femoral pulses are symmetric. Which of the following is the most appropriate next step in management? Guys, what is this guy having? What is this patient having? Yes, but what is he having first? Exactly, this guy is having MI, right? Probably acute coronary syndrome. We don't know if it's MI or not. A huge probability it is. So what do we need to do? We need to do the ECG first. Okay, so guys, in coronary artery disease, we do ECG. In and structural heart disease like pericardial and myocardial disease, we do the echo. Okay, guys, so we have finished our session today. Thank you so much for being interactive, and I hope it was helpful. And hope we've covered lots of info in the time. And actually, those are the most important and highly tested things in cardiology for step 2, and it also for step 3, and it may even benefit for step 1, as we have said. Guys, again, if you like our ways of teaching and you need more help with one-on-one tutoring, someone to help you with individualized plans, And to guide you through a difficult situation, reach out to us if you're interested in one-on-one tutoring, and we can arrange a 30-minute free session for you. And also check out our high-yield PDFs, and you can also try our Synapse QBank for free if you're interested. Thank you so much, guys, and see you. Bye-bye.